I am Dr. Charity Watkins. I am an assistant professor at North Carolina Central University in the Department of Social Work. I'm also a Birch Scholar, or Building Interdisciplinary Research Careers in Women's Health Career Development Award Scholar at Duke University in the Department of Obstetrics and Gynecology. So I actually, meant to change that. I'm actually at the intersection of both physical health and mental health, and also thinking about the psychosocial effects of severe maternal morbidity. So let's get started. I do not have any conflicts to disclose, and I'm grateful for the funding that has made this presentation possible through Birch. And I want to go ahead and start off by telling you what you should expect from this presentation. So overall, I want you all to walk away with knowledge of the prevalence, significance, and consequences of racial health disparities in maternal health. I also want you to walk away with insights into the complex history of social work. Now, I know not everyone on the call are social workers, but I want you to probably do some deep diving into your own profession to think about, what is my profession's connection historically to women's health? So I will model that with social work, but I also want you to do some reflection about your own profession if it's not social work. And then we'll end with some innovative strategies for social workers, but also how you can apply it to promote health equity and maternal health excellence. So y'all ready? All right.
Okay.
I also start off with a clear description of my position in this work. So I am a Black American and a woman, cisgender woman, and I understand that I am going to enter that space with those identities no matter what. And it actually shapes all the time how I engage in my field, how I engage with my students, and also how I conduct research and how I show up here in presentations. I am personally deeply connected to this work, and I do not shy away from acknowledging that my own experience of severe maternal morbidity directly informs how I reach out and how I research. And so I encourage you not to see my Black womanness as separate from my professional presentation, but rather see it as personal experience as a Black woman, as meaningful form of expertise, and that my story is a case study that I have the privilege of sharing directly with you, and have now figured out ways to position myself to enact change and prevent its repetition. So I want you all to think about what your position is in this work as we move forward. And again, I am one case of severe maternal morbidity, just one, but I do recognize that there are commonalities across many cases. So in order for you to know my story, I usually share quite a bit about it, but in interest of time and really wanting to get to the rest of the content of today's presentation, I'm going to share a video for you that I recorded with Women Heart Champions through the National Coalition for Women with Heart Disease. I found out I was pregnant while I was a doctoral student at the School of Social Work here at UNC-Chapel Hill, and I could not be more excited to welcome a baby as my first one. Overall, I was healthy until it came time to do the test for gestational diabetes. I was being very careful in terms of how much sugar I was eating, how much salt was in my diet. I was exercising. I was walking almost 5 miles when I was in my third trimester. However, I was feeling very tired. I remember going and having to apply for a handicap sticker in order to park a little bit closer to where the bus actually picks up. We had an unplanned cesarean delivery. In the initial day, I believe, following her birth, the doctor came in and he came in after I had some complaints about bleeding. And he literally manually removed blood clots. After a while, I started to feel really tired. That was the question I asked myself. Is this something that, are you supposed to be this tired following, childbirth? It got hard to eat and breathe. And I was also told by my obstetrician that maybe I was experiencing some symptoms of postpartum depression. And then I also realized that my physical symptoms weren't getting any better. And I remember having this sharp pain in my left arm. It was just kind of like a radiating pain in my arm, and it didn't go away. So we drove to the ER. We went through the triage process. I left the triage only to sit in the emergency room, waiting room for 5 hours. And mind you, I think these are symptoms of some kind of heart condition, but it wasn't escalated to the point of me going beyond triage. And it felt a little demeaning. I didn't feel like my symptoms were being taken seriously, only leaving because I needed to feed my baby again. I was really concerned about, whether she was going to be able to eat while I was gone. On Monday, after going through Saturday and Sunday with the same, feelings, I called Campus Health. And I remember the doctor ordering that I have an x-ray taken of my chest. He said, well, we looked at your x-ray results and it looks like you have an enlarged heart. I think we need to take you down to the emergency room. So I was rolled in a wheelchair down to the emergency room. When I look back, I think about how bad I felt, despite how I portrayed myself. I didn't really think about it when I was pregnant. My mom and my dad both have heart failure. There are so many places where either I could have been diagnosed sooner or even, told that I should look out for these kinds of symptoms or signs while pregnant. But it wasn't until I was so close to not being here anymore that I finally received that diagnosis. And I can't help but to think, it didn't have to be that way. All right, so if you all with me can just take a deep breath. I know it's my story, it's me talking, but sometimes it still just kind of hits a little bit differently for me. And so I want you all to kind of think about what you heard in that video as I talk just a little bit about my diagnostic journey. Again, I did not have any existing conditions before this. I actually had never even spent one night in the hospital. The most I did was a wisdom tooth extraction. And that was with laughing gas. That was literally the only type of surgery I had before having an unplanned cesarean delivery. And to have experienced shortly after that, the only type of surgery I've ever experienced, the only time I had been admitted into the hospital to have a doctor manually remove blood clots in my room with my sister-in-law there holding my daughter and my father waiting in the waiting room to see me and his grandchild for the first time. It was devastating. It was scary. I didn't know what was going on, and then, of course, to go home and experience this shortness of breath, this nagging cough that wouldn't go away. I couldn't lay flat on a pillow. I had nausea and vomiting later on. It was hard for me to even change my daughter's diaper without getting sick. This chest pain that started to develop, and then just overall difficulty breathing. To have gone through, because I was a doctoral student, I first went through everything I could in terms of preparing for my pregnancy. I went to birthing classes every week with my husband. I went to prenatal yoga. I read all of the books. I treated it as the most important research project I ever had. But yet that did not prevent me from experiencing this and experiencing this delay in my diagnosis that really could have been fatal if it wasn't for being able to get an appointment with Campus Health within a day. I actually talk to my cardiologist every year. Actually, it's about time for me to schedule again, but she tells me often how close I was to not being here anymore. Very close with my heart. It was only functioning around 5 to 10% when I was first diagnosed. I have since being diagnosed initially have gone through genetic testing and have found that I have a genetic trait that has made my heart muscle more likely to experience weakness. And so I have had that genetic testing. My father has had that genetic testing. I realized that it has been passed down to me from my father. Unfortunately, wasn't able to get my mom tested before she passed away in December 2019 from cardiac arrest. But I also have had my daughter screened for the same genetic mutation, and we have already began seeing a cardiologist. So at the age of 8, she has a cardiologist now. So this is long-term multi-generational impact. It could have easily though been where I wasn't here to make those connections between my father and his diagnosis, and now thinking about my daughter and what her life will look like with potential heart failure. So this is something that could have impacted not only me but entire family and multiple generations. And I have to realize that unfortunately my story is not unique. Maternal mortality and morbidity in the United States is outrageous, especially thinking about how much money we spend on healthcare. We spend the most, but then have some of the worst outcomes in terms of maternal health. So the United States has the highest maternal mortality rate among high income countries. We have actually over a period of time, it had experienced an increase. It has recently slightly decreased, but it still is far exceeding the rates of similar countries such as the UK, Canada, France. We are just above the line for Chile. So we are looking at rates that should be a lot better than they are, especially for being such a advanced country in terms of economics. But clearly, money does not equal health necessarily in our country. Also, annually around 60,000 birthing people experience near misses or unexpected outcomes of labor or delivery with serious short or long-term impacts on their health. So that would be the maternal morbidity. And I have to say that those numbers are actually significantly underreported because um, much of our data on maternal morbidity only accounts for morbidity that happens during pregnancy or not, excuse me, actually only during labor and delivery, not prior to labor delivery, nor the year after labor and delivery. So we actually probably have higher rates of maternal morbidity than we even have accounted for. And also, we don't always know what may be the cause of death of a person who was pregnant. It may have been related to pregnancy. It may have been something that happened within the year that was not pregnancy related. However, just to note that data, we always can do better with data and how we collect it, and also how we're defining problems. Cardiovascular conditions actually account for a significant proportion of both maternal deaths and severe maternal morbidity. Black women are actually significantly more likely to experience cardiovascular conditions and to experience maternal deaths as a result of that. And overall, I think the most outrageous number that we have is 84.2%. 84.2% is the percentage of maternal deaths that are preventable. That means we could have done something to save these individuals' lives, to keep these families intact, to have birthing people alive to support their babies. These are people that we're talking about that are no longer here because we didn't do something. That's what it boils down to. We didn't do something to keep these people here. And so 84.2% is a number I want you to always keep ingrained in your mind until that number starts to go down. And of course, we have racial disparities in maternal mortality and morbidity, just like we have pretty much in any other health condition. Black women fare worse than non-Hispanic white women despite educational level, income, or insurance type. So this isn't boiling down to individual factors such as, did this individual have access to quality health care in terms of insurance? Now, we could talk about quality health care outside of insurance type, but whether you have Medicaid or whether you have private insurance is not a factor that's going to help us in this situation. 3 to 4 times, that's the rate. Black women are losing their lives compared to non-Hispanic white women, 3 to 4 times more likely to die while giving birth. Black women are also 2 times, actually 2 to 3 times more likely to experience a life-threatening medical event during childbirth. And this last point here, Black women with graduate level degrees, that includes myself. That may include other folks on the call, but Black women with graduate level degrees and with the highest incomes, I'm not going to say that part applies to me, but are more likely to die than white women with less than a high school diploma. Black women with graduate degrees and high incomes are 5 times more likely, 5 times more likely to lose their lives giving birth. That is outrageous. And it does not come down to individual factors such as how you eat, whether you exercise, what kinds of activities you're doing, what kind of prenatal care you're receiving. This is boiling down to one thing. And it's not just happening because of someone's race, it is racism. I'm going to say that very clear. It's not race that is the problem, it is racism. And we have started to delve a little bit more into this, especially with our discussions on social determinants of health. So we have identified some factors outside of the healthcare system that contributes to what kind of outcomes, health outcomes one experiences. And so these social determinants of health, the diagram here provided under the Healthy People 2030 goals, identifies healthcare access and quality, neighborhood and built environment, social and community context, economic stability, and education access and quality as factors, social environmental factors that may impact one's health. And I have to say, as a social worker, we've been know this. We've been using this model of person and environment for so long. It is at the core of our work. And so people, I view, are just catching up in the health arena, but we have already understood that individuals are not living, growing, praying, and working and aging in a vacuum. They are surrounded by factors that can contribute to their health in positive ways or negative ways. And so we have to acknowledge that, but also acknowledge another piece that racial bias and structural racism are going to directly impact those social determinants of health. I have seen, and I try to take a deep dive into this a little bit before the presentation, but I saw on the Healthy People 2030 website that racism was identified as a social determinant of health. However, it did not show how racial bias and structural racism actually impacts all parts of this model. It affects what kind of education access and quality you have. It affects your economic stability. It affects your neighborhood and built environment. So we can't treat racism as just one of those factors under this beautiful model, but actually as something that is affecting the model itself. It is at the foundation of how this model works and how it carries forward. And so if we think about this in terms of maternal health, we talk about racial discrimination in provider interactions. We have to acknowledge that. And racial bias can be implicit or explicit. It can be where folks mean to discriminate against you, and it also can mean that people have not the intention of discriminating, but it still has the same impact. Also, in terms of weathering and allostatic load, these are theories and findings that have talked about the cumulative burden of stress and race-related stress specifically, how it literally, that daily mundane experience of racism every day of your life actually contributes to your body aging sooner, like your biological aging is out of this world because your body is producing these hormones on a regular basis in order to kind of physiologically react to threats, perceived threats. But then when that never goes off, it is literally causing your body to age quickly. It's also causing more likely for you to experience cardiovascular disease, diabetes, and other health disparities that we have seen in Black people specifically. In this allostatic load, where we typically have a way of having this balance in our body, we may react and release cortisol, for instance, when we are in a stressful situation, but it usually turns off when that threat is no longer perceived. But how do you turn off the threat of racism? I'm not sure if it ever goes off. I don't think it does. And so that allostatic load and that weathering happens over time, which means that our health is impacted directly by racial bias and structural racism. And of course, when we think about obstetric racism, I'm going to break that down a little bit more in the presentation, but we're talking about how this plays out not only in interactions, but also within healthcare systems. So this is not just about talking about individual providers and what individual providers need to do. It's also talking about what health systems need to do and all of those who are a part of the system. And when we're thinking about manifestations of racial bias or structural racism in healthcare, it can come in a lot of different forms. Here is a table that was developed by Rachel Hardiman and colleagues that kind of identifies the different manifestations in healthcare according to interpersonal, um, institutional, and structural racism. And there's also the identity or the piece of internalized racism, in which you have been told over and over again that because you have these inherent differences, that you are going to receive differential treatment. Sometimes after hearing that so often, that you start to believe it. You start to believe, I don't deserve that kind of quality care. I am in this position because of something I did. And so we have to realize that internalized racism also plays a part in this. But I would say that it's the interpersonal, institutional, and structural racism definitely that plays the biggest part. And we can talk about communication failures, we can talk about differential treatment, but also a lack of resources and policies that would support equitable care for all. And this table here actually, or this visual here actually provides you with what are the actual domains or uh, the way that obstetric racism can be broken apart. And so obstetric racism is obstetric violence plus medical racism. And obstetric violence is defined as the control and dehumanizing treatment of obstetric patients due to the actions of medical professionals and staff. And I have to note that obstetric violence is not talking about race. That can be applied to any patient who is in labor and delivery. And so dehumanization and control can happen to anyone, which is probably why we're seeing why these numbers in terms of maternal mortality and morbidity aren't good for anyone. We have work to do in terms of supporting birthing persons of all races. But then when we add the component of medical racism, which is the occurrence of medical care provision, including treatment or diagnostic decision-making processes being influenced by the race of the patient. That means we are in our minds, we see a person's skin color and automatically maybe something that we learned in medical school, maybe something that we were taught within our training triggers a flick of the switch that tells us, oh, I remember that it said that, for instance, Black individuals had experience pain in a different rate than white patients, or they had thicker skin. Like, these are things that have been taught within the last like couple decades. And so if that switch automatically goes off when you see someone that you have perceived as being African American or Black, then that in itself, that is an implicit bias that happens that triggers medical racism And if there's also experiences of obstetric violence occurring, that in itself can lead to obstetric racism, including diagnostic lapses, so delays in being diagnosed and receiving treatment. Also coercion, kind of being told what procedures you're going to undergo without conversations and shared decision making, neglect, dismissiveness, or disrespect, ceremonies of degradation. I see this one, you have to think about it as this is something that's built in. This is not something that someone is just kind of by chance choosing to do, but it's a part of how things work. It's a part of how things work. Intentionally causing pain, medical abuse, racial reconnaissance, all of these factors contribute to how obstetric racism plays out. And I want you to keep these points in mind. First, racism is baked into the normal functioning of our social systems and institutions. So this is something that it's there no matter if we choose to see it or not. Racism exists no matter what. And it exists in a way where we don't see it right away. It's almost like when you drink water, you're just hoping that it's clean, right? But we are all exposed to the same systems of racism. It affects us differently, but we are all taking in that water. We are all breathing that air. And so we all therefore have a responsibility to identify it when it happens and do things to change it. We are all vulnerable to racial bias, all of us, because of it being baked in, because of it being normative and a part of our daily lives. And racism can be conscious or unconscious. Sometimes we can get a little looped into, I didn't do it on purpose, or that wasn't my intent. But I always say to folks, I understand that intent it matters so much, but we also have to put as much weight on the impact that it has on the individual who experienced it. So now I'm going to start drifting into that social work mode. So if you are a fan of social workers, I would love to see your cheers because we do some hard work, but we also have some more work to do. So social work, if you're not familiar with our field, is a profession and academic discipline that addresses the needs of vulnerable and underserved individuals, families, groups, and communities by promoting social change, advocating for social justice, and challenging social inequities at micro, meso, and macro levels of society through direct practice, policy, and research. Very long, but I think one of the or 2 points that have been that need to be highlighted here is the fact that we are serving vulnerable and underserved individuals. And we're serving them not just as individuals, but acknowledging the inequities that happen at the individual level or micro levels, as well as the meso and macro levels of society. And we are choosing approaches that allow for us to have the largest levels of impact. So yes, direct practice has impact, but also policy and research does too. And social work works so well with health disparities research that examines the influence of environment, social determinants, and other underlying mechanisms leading to differences in health outcomes. That aligns perfectly with social work. And I would have to say, and this is just coming from me, but social determinants of health, that stems from social work. That's us. But I want you to think about in terms of social work direct practice, but also our roles in academia. So as professors, as colleagues, as those who are providing service to universities and other institutions, social advocacy and the way that we may engage in that as social workers, our community engagement, and also how we are oftentimes approaching our work in an intersectional and critical theoretical perspective. So we are looking at systems in order to take them apart to understand why they operate the way that they do, who benefits from this system in the way that it's operating currently, who doesn't, where does the power lie? And then lived experience is such an important piece of expertise that we don't always give credit to, but it literally allows for us to put ourselves in the shoes of someone else when we can say, well, I can reflect on my own personal experience to think about how this may be affecting this other person or this other group or community. And so my desired impact for my work has been to reduce the occurrence and negative outcomes of cardiovascular related severe maternal morbidity, or SMM, among Black birthing persons from the professional stance of a social work community engaged researcher. That I want to say, I want to put that out there as that's my desired impact for all of the work I do, whether it's a presentation or a research project. And so with that desired impact in mind, I started finding myself wondering, so where has social work been during this maternal health crisis? Where have we been? And I, try to get used to using a lot of different forms of technology and put a bit of a description in Chat GPT and said, generate me a image of a social worker in a very large group of Black women. What would that look like? And I wanted to have her dressed as, oh gosh, I forgot his name, but you remember those books where you used to have to find the person among all of these other folks. And so I thought about it, I was like, we have Black women who are gathered here and supporting each other in different ways, but then we're trying to figure out, how are we engaging with social work? How is social work engaging with communities? How are we seeing interconnection? How are we seeing relationship building between social work and Black women in terms of supporting maternal health? And so I started doing a little digging into social work and healthcare, and where are we? We have healthcare social workers. That's actually a title that is under the U.S. Bureau of Labor Statistics, along with a description of what we do. But over 25% of social work jobs are held by healthcare social workers, and around 17% work in outpatient healthcare settings, with 9.5% working in inpatient hospital facilities. And social workers can have a lot of different roles and functions in healthcare, including behavioral health, case management, care coordination and navigation, interprofessional teams, as well as integrative team-based healthcare teams. And so I want to actually kind of break down what this is. And I'm sure that this is at a big piece of what we're talking about today, is this integrative team-based professional healthcare, and how two or more healthcare professionals from different fields, specialties, are able to work collaboratively to almost simultaneously meet the needs of patients and their care supporters. So instead of saying caregivers, I say care supporters, in efforts to promote progress toward health goals, facilitate shared decision-making, and also foster greater communication between professionals and patients. And so there's a lot of different benefits to integrative professional healthcare, including improved health and service utilization. Patients are more likely to keep appointments and to come to them. Also reduced ER visits and inpatient hospitalizations, most often because there is higher use of primary care and psychiatric services, as well as other preventative services to avoid ER visits, and also improved perception of overall health and access to mental health services. So there's a lot of benefits to people working together for the benefit of patient health. And this has, been relevant for social workers, but we also are still in the mode of integrating social workers in a deeper, more meaningful way. But here are some of the roles that social workers currently hold in maternal health care, including case managers, patient care navigators, perinatal social workers, genetic counselors, as well as home visiting program social workers. And what you will see here is that there is a consistent line of social workers addressing the psychosocial effects of health, but also helping patients to understand and access healthcare resources. And so we, even within our current roles, are working at multiple levels. So yes, we are working directly with patients, but we're also helping patients to work with their providers, to work within systems. And so we may do it in different ways in terms of case management case managers, for instance, compared to home visiting program social workers, but we are maintaining that role of person and environment in like ecological systems and how individuals are able to maneuver and navigate those systems. That is something that is going to be consistent in our roles. But I just think that there's some ways that we can strengthen that. And so there are some current challenges to social work integration in healthcare, including workforce shortages, generalization over specialization. And what I mean by that is that we in social work, many of our programs, our educational programs, are pushing more for a generalist way of learning. So learning a lot about different areas of social work, different settings in which you can practice social work, but then that means that we are less often having social workers who are coming out with training in a specialty. And so it's almost kind of like the debate between jack of all trades, master of none, that at times can show up within our students when they go out into the field after graduating, because they are still of course in the mode of learning and developing their skills, but it's a little bit harder to sell yourself as a health social worker with these particular skills if your education has been more wider range. Also, role ambiguity. Social workers, we have had our title used to express or describe a lot of different people. And we also, as social workers, have been given a lot of different titles: behavioral specialist, case manager, case coordinator. That means we are starting to dilute what our role is. And also when behavioral health is now, it's something that can be delivered by social workers, but it also can be delivered by nurses. It can be delivered by psychologists. It can be delivered by psychiatrists. And so there's this role ambiguity, like who's doing this work? What is your training? And how does that relate to what you're going to do with patients? And also professional validation. Social work, I would say, has done uh, yeoman's work of trying to develop or to be seen as a profession and not just something that you do to help people. Like, we're doing a little bit more than just helping people. We are also applying different theoretical models. We are applying standards of care within our profession. And so we are oftentimes seeking this validation, especially within contexts like healthcare systems, where there's such vast power differentials depending on what letters are behind your name and what role you hold in a hospital setting. And so while we are trying to be validated by these other professions that have already without question received validation of their role as a important profession, we are still seeking that in many ways. And also competing professional values and ethics. Sometimes how we view our work, especially with a social justice lens, does not always align with other professions. And sometimes it can even run counter. Oh, forgot my arrows. And there's some additional challenges that we face as social workers, including mandatory reporting. Now, this is something that we are obligated to do based on our profession. And actually, many folks in healthcare beyond social workers are mandatory reporters. When we see that there's a potential case of child abuse, neglect, elder abuse, neglect, violence, we have to report it. And so that in itself means that there can be some bonds of trust that are lost between us and patients when we are in the role of reporting. Also, that relates to criminalization of parenting and poverty through child protective services. I actually just heard recently some discussions of this among community members, in which, just hearing how social workers are viewed as an extension of the police. And that can be very problematic because we are a helping profession. And if we are viewed as more of policing versus helping, then that's going to affect how we are pulled in when we're needed. That's going to affect whether we are working on levels of trust, or are we distrusted as a profession? And so that in itself also creates a challenge in terms of how we engage with patients. Also, racial discordance. A vast majority, I believe, over 60% of social workers are identified as white, and yet many of the individuals that we serve, vulnerable, underserved, tend to be people of color. And so this racial discordance also, very much like the research that we see on patient concordance, racial concordance within healthcare, it also contributes to some levels of distrust, and also creates some blocks or barriers to relationship building. And racial disproportionality, which means that we have a higher number of Black children, for instance, that are being entered into the child protective services, who are being, pulled from their homes, unfortunately. We have this higher rates of Black children and Black families experiencing the outcomes of our work compared to other groups, which again contributes to less trust, contributes even to contention and anger between or from patients or individuals in the community and social workers. And then we also have to acknowledge, and I'm going to do it very quickly, social political climate around diversity, equity, and inclusion, social justice, and reproductive rights. We have to acknowledge the current context in which we are all operating and how that may affect our work. And social workers, something that I like to do is acknowledge our history and acknowledge what potential roles we played that were harmful in our history. And I have to acknowledge that social work has been complicit and sometimes explicit in their harm of Black women. We had played up to very recent history a role in eugenics ideology and violence. Actually, Jane Addams, one of our amazing founders of our field, was identified as a honorary vice president of the American Social Hygiene Association, or ASHA, which identified, for instance, sex work as a social evil, and really pushed forward with the idea that poverty was a social evil. We needed to cleanse, basically, our society of these individuals who experienced poverty, who engaged in sex work. You can understand kind of how that could be problematic moving forward. And also, I think about Mary Richmond in our Friendly Visitor program. Friendly Visitor asserts that people believe that the person coming in is friendly. That's an assumption that that term is folded into it. But many individuals are not seeing social workers who are just dropping by their home as friendly visitors. They're seeing them as being you are entering my safe space, and you are looking at how I live, and therefore making determinations on my ability to parent based on your visit here, your friendly visit. And so we have to think about how this plays into, for instance, us being viewed as social services gatekeepers. We determine your qualifications and eligibility for help. We also are engaged in surveillance via child welfare. Of course, criminalization of substance use disorders, especially during pregnancy. And oftentimes, I have to say, we are in the mode of having to forego our social work values in the pursuit of professional validation. And so that can be difficult and challenging to almost be in catch-22, where you're looking for this validation, but you're also at the same time kind of turning your back on the core values of your profession. And I will say that we still use some of these tools today. This is a genogram. I remember teaching this to my graduate students when I taught one of my social work courses. And it is actually a pedigree chart. This is something that was used more with animals in husbandry versus with people, but it's still something that we talk about in use today. And so where do we go from here? I developed this model called the 5 A's: acknowledgement, accountability, acquisition, adaptation, and action. Let's start with acknowledgement. Here is a perfect example of how you acknowledge your history as a profession and what you say you're going to do moving forward. This is from our National Association of Social Workers, in which there was an apology for racist practices in American social work historically. And so we, for instance, uh, apologize and acknowledge our role as a profession in segregated settlement houses, in blocking African Americans in the suffragist movement. We also acknowledge how we supported eugenics theories and programs, among others, including the engagement in helping to recruit for the Tuskegee experiment or Tuskegee syphilis study. So we here had to acknowledge what part we played in this, because if you don't acknowledge first, it's hard to really move on and say, well, this is what we're doing now. You have to acknowledge what harm you caused in the past before you're able to move forward. And I'll have to acknowledge that it was our dear NASW president, Dr. Mitt Joyner, who actually put this information out and put this apology out. And she was a Black woman. She was a Black woman who took this step. And so I acknowledge the role of Black women, even with helping our profession acknowledge our history. In terms of accountability, we have our National Association of Social Workers Code of Ethics. Every single student who enrolls in a social work course learns these values and principles. Every single person: service, social justice, dignity and worth of the person, importance of human relationships, integrity, competence. These are values and principles that govern how we work with patients or clients, but also how we engage with each other, also how we engage with our communities. And so we have something that tells us how we need to engage, but whether that actually shows up in how we practice is another story. But I think we have the model here. We just need to make sure that we are exercising it anytime that we can. In terms of acquisition, and I like the A's, but acquisition, I would say acquisition would say is more about how do you acquire information from others while giving them credit, acknowledging where you got that information from, acknowledging that yes, you have learned from this model and you are asking how you can adapt it moving forward. So there's some acknowledgement that comes along with that acquisition. And I think social work is a perfect field for this, because we have honestly two different ways of approaching social work, actually probably more than that, but there is the Eurocentric social work model and also more of an Afrocentric social work model. We actually have a National Association of Black Social Workers, national, so we have a specific organization dedicated to social work done in Afrocentric way. And so Eurocentric tends to highlight individualism, while Afrocentric social work is talking about interconnectedness. And if you think about those integrative teams, those interprofessional teams that we're talking about, that's where it lies, in the interconnectedness, and also realizing that the relationship for one person actually connects to the other. And so if my future is connected to yours, then I have a stake in supporting you. And that's going to be different than individualism, which is more about what does it mean for me. Scientific evidence is based on objective findings, while there's more of a spiritual nature. There's more of a sense of I understand that experience itself is a form of data that is not just about what can be objectively measured, but also the spiritual nature of individuals and how that shows up. And so just giving you some sense of there are models out there already. We just have to be able to recognize that we don't have to recreate the wheel. We also need to give credit to those who have already been doing this work and ask how we can apply it in a larger way. And that includes centering Blackness, including learning and turning to folks who are already doing the work, including Black-led organizations. I've already mentioned NABSW. Also trusting that individuals who experience these things are experts in their own experiences. And we also don't want to engage in health equity tourism, where we're just going from depending on what is being funded right now through NIH, that's what we're concentrating on. We want to make sure that we are seeking impact for those who are directly impacted, not just seeking individual fame or fortune or the next R1 grant that you need to go for. Adaptation. So what I have thought about is how we can adapt this idea of working at the micro, meso, and macro levels, how we as social workers or care teams overall can work directly with patients around patient empowerment, around helping patients to identify their symptoms, and also providing culturally affirming interactions that extend beyond drug tests and immediate healthcare needs. How can we build relationships with patients? Also, how can we help patients and providers build relationships that are hallmarked by positive patient-provider interactions? How can we ensure that we are interrupting implicit bias and helping individuals to acknowledge when that bias occurs? At the macro level, how can we infuse social work values and principles into the perspectives of interdisciplinary work? How can we bring that the dignity and worth of a person is paramount within the work that we do within healthcare? And also, how can we really help develop a standard of care for social work and other fields within maternal fetal medicine? In action. Again, I am one example of how social workers can combat the Black maternal health crisis. And I really did leverage the privilege I had in the many roles that I have to lessen inequities. How can I use my education and the spaces that I'm able to um, walk through and navigate? How can I use that to lessen inequities? And so I have thought about survivorship through scholarship service and social advocacy, including scholarship as a Birch Scholar, where I am working currently on a study. I'll give you a little bit of a glimpse in it, but I'm also doing manuscripts. I'm writing those and submitting them for publication because I know that that speaks more to the professional realm, but also it helps me with being able to show that there's expertise and experience. Also serving as key personnel or expert advisor for federally funded research projects, and of course, advising my MSW students. I'm always thinking about how I'm helping the next generation, and scholarship is a part of that. Here's a look at my current project that I'm working on for my Birch Award, in which is a mixed methodology study that is seeking to help us identify the role and function of social workers within maternal health care specifically, and how we can better support women who have experienced cardiac severe maternal morbidity with life after maternal morbidity. I'm also thinking about service. So I'm serving in multiple roles, but what I really want to highlight is as the board chair of a local nonprofit community grounded organization called Equity Before Birth. This was us, including my daughter and State Senator Natalie Murdoch, during our dance party this year, where we celebrated Black Maternal Health Week, and were able to celebrate the families we've been able to serve through Equity Before Birth. The mission of Equity Before Birth is to save the lives of Black birthing people and infants through a number of different services, including doula services, midwifery care. We're connecting individuals to all of these different services with core values of trust, accountability, autonomy, transparency, and power sharing, among others. I'm moving a little quick because I want to make sure that I wrap up with you all, but I did want to also highlight the social advocacy that I'm engaged in, including speaking to the North Carolina legislature about the importance of Black maternal health and also heart health. Have done a number of different talks over the last 3 years around Black maternal health and women's heart health. But now I want to point out what social workers can do, but also what you can do Take ownership of the unique skills of my field, but also your field. Seek out opportunities to leverage your skills in maternal health spaces. Apply the micro, meso, and macro system perspectives to your practice. Actively participate in research with patients and communities. Recognize the intersections in research, policy, and practice. And overall, demonstrate moral courage. It is not easy to change systems. It would never be comfortable, but it requires us to do it anyway. So what I'm calling for you to do, discuss racial maternal health with your students if you are engaged with students. Embed storytelling within your content with students. Practice, ensure that you are applying those 5 A's, doing that work of combing through your own profession to see historically and contemporarily what are some ways that we are contributing to the harm in order to correct it. And also engaging in that research and staying up to date in policy. Oh, we definitely need that, and we definitely need folks to be civically engaged. And so my challenge for you at this point is to identify your multiple intersecting identities, recognize how your personal and professional selves are intertwined, seek out opportunities to use privilege to interrupt oppression, take ownership for both your intentions and impact, be a lifelong learner, and again, demonstrate that moral courage. We need it at this point, and we can't wait for it any longer. And so I dedicate this presentation to my mom, and also to the reason of my heartbeat continues to beat, my daughter Margot. And so I want to thank you all for your time. Please stay in contact. I'm pretty easy to find online, Charity Watkins at Duke or NCCU. I would love to hear from you, love to hear your thoughts. I'm sorry that I may have used all of the time, but I hope that it was a helpful presentation. I hope that you gained something from it, and I would love to hear any thoughts that you may be able to share within the next couple of minutes. But thank you again for your time.
Thank you so much. I appreciate your time. And I'm just going to do a quick few housekeeping if people want to stick around for just a moment. So thank you so much.